I have heard there is yesterday we were discussing that if you give neoadjuvant chemotherapy, EVPM or whatever, and before surgery the ctDNA is positive, that some people say, oh, there is no need to do surgery. That is based on an assumption, so we don't have data. Because if we review the data that was reported on ctDNA in the Niagara trial, you see that before starting the neoadjuvant platinum gemcitabine durvalumab, there are 50% of patients, or around 50% being positive. After neoadjuvant therapy, there is a decline on the positivity of ctDNA to 22%. And then these patients go to surgery. After surgery, these 22% become 9%, meaning the surgery is maybe removing the source of the spreading of the DNA. So I think that presently we cannot make decisions on the dynamics of ctDNA. Is helping. People is using ctDNA not only in this perioperative space. We are using now in patients with metastatic disease. Is an easiest way to say, okay, this treatment is working. If you see the DNA going down and up, the best way to use the ctDNA is in patients that have like a single metastatic location that has been completely resected. And in addition to do scans, PET scans, and so on, you can monitor with ctDNA. If this patient was having ctDNA before, there are tumors that are not shedding DNA, and this is something that we have seen. There is, for example, specific metastatic locations that are not shedding DNA. As mentioned, in the IMvigor011, we saw that there were 12% of patients that the disease recurred having negative ctDNA after a year, meaning that it's not a perfect tool.